When you hear the words cancer treatment, do you only think of chemotherapy? Today, I sit down with Dr. Jason Konner, a medical oncologist at the renowned Memorial Sloan Kettering Cancer Center. Dr. Konner specializes in gynecologic cancers and has spent the last 2 decades witnessing how cancer treatment has rapidly evolved. You'll learn the key differences between traditional chemotherapy, targeted therapies, and immunotherapies, and why it's important to know which one is right for you. We'll also talk about how doctors decide on a first-line treatment, what to ask when a new drug is recommended, why getting a second opinion is not only okay, but often encouraged. Stay until the end to hear the surprising factor that could make immunotherapy less effective, something most patients never think to bring up. Let's dive in. Hello, everyone. I'm Dr. Katie Deming, and this is the Born to Heal podcast, where we explore holistic practices for cancer prevention and healing. Let's welcome today Dr. Jason Konner, medical oncologist and full professor at Memorial Sloan Kettering Cancer Center. Welcome, Dr. Konner.
Nice to be here, Katie.
So, Dr. Konner, I am so excited to have you on the show. And what I wanted to bring you on to talk about is the different types of therapies that are available for people who are healing cancer from a conventional standpoint. And I know specifically you are a medical oncologist, but a lot of people actually may not even know what a medical oncologist is. So I'm wondering if you can describe kind of generally what are the different types of treatments, and then what does a medical oncologist do? What are the treatments that fall under that? And then we'll go deeper into explaining what those types of treatments are and when people would seek them.
Sure, absolutely. Well, the very basic categories, there's surgical oncologists who do surgery and radiation oncologists, as you mentioned, do radiation. And those are mostly for local treatments of cancers in a variety of parts of the body. And then you have medical oncologists who do everything else. And much of what we do from a therapeutic standpoint is give what we call systemic treatments for cancer. And by systemic, we mean treatments that go everywhere in the body. And so very simply, you can break that down into traditional chemotherapy, targeted therapies, and immune therapies. I would say are the big 3 categories there. And, the traditional chemotherapies are mostly developed in the 20th century, but are still very present for many cancers. And those are basically treatments that are usually intravenous, but can also be pills, and that go in the body and basically kill dividing cells. That's what they do. And they can do that through a variety of different mechanisms. So there's dozens of different cytotoxic chemotherapies out there. They all have their own side effects and specific cancers where they work better or worse. And, much of what we do is figuring out which are the best chemos for this particular disease entity and for this particular patient, and help prepare them for, what are the challenges of those treatments. And systemic targeted therapies, really are mostly from this century, starting kind of in the late 90s, but very much in the last 20 years. And those don't necessarily just go into the nucleus and just break up dividing cells by attacking the DNA, which is mostly what the cytotoxic chemotherapy do. What targeted therapies do is they go after some of the biologic mechanisms of cancer growth and try to inhibit them. So a common example is cellular signaling. Cells decide to divide or not divide based on chemical signals that are taking place in the cytoplasm. And some of those signals are amplified or inhibited in specific cancers, and those can be targeted by targeted therapies. So very often you might see a cellular signal that's just turned on, and it's because of a mutation. The protein is saying, grow, 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 keep growing. And by identifying that in a specific patient, sometimes we have usually a pill that can block that mechanism and ask the cell not to divide. And then finally, the third category I mentioned were immune therapies. And that's an umbrella term for any sort of treatment that basically in some way stimulates a patient's own immune system to help fight their own cancer. And there's a variety of ways of doing that these days. And that's really just the last 15 to 20 years that we've seen that come into the fore. But it's really had a transformational effect on the way we treat many cancers these days.
Well, and I'm wondering, you brought up a word cytotoxic, and I think that this, just so that people know what cytotoxic means, is basically it's killing the cell. So it's toxic to the cytoplasm or to the cells. And so, when people think of chemotherapy or systemic therapy, often they just bucket this all together and they think everything is cytotoxic chemotherapy, which, as you describe, it's not. And more today, we're using these other therapies like targeted agents or immunotherapy that really have a different approach. Their approach is not to kill the cell, but to either boost the immune system with immunotherapy or to block a specific mechanism within cell signaling. I'm wondering if you can describe, because when people, hear cytotoxic chemotherapy, they think, oh my gosh, no, I don't want that, because they're thinking of all of the traditional side effects of hair loss, nausea, vomiting, weight loss, feeling super fatigued. I'm wondering if you can describe what is the difference when someone has, let's say, immunotherapy? Like, what is the and I know it's so complicated. These are like such general questions. And just so people understand, is Dr. Konner is a medical oncologist who specializes in gynecologic cancers. So this is very, very nuanced from there's so many different drugs and it depends on the type of cancer, right? And so, your scope of practice is like really narrow because it is so nuanced with this. There's so many different places that people can go. So I just want people to know that we understand this is a very complex topic, and we're taking broad strokes here just to help people understand so that when they go in to meet with a medical oncologist, they feel more informed about what these different types of therapies are. So what are like some of the differences in terms of the side effect profiles that you could think of targeted agents or immunotherapy versus conventional therapy?
Yeah, well, it's a great question, and I could talk for days about this, literally. But the details really matter because there are so many different types of treatments, and so many different types of cancers, and so many different types of patients' bodies, and the way that they react with these medicines, these diseases. And there are such individual differences, but very often when a patient is newly diagnosed and they're not very familiar with cancer and its treatments, they may say, well, I knew this person and that person was very thin and bald and sick, and I don't want to have that experience for me. Or they may know someone who said, oh, they just took a pill and everything went away and they were fine. And I hope that can happen for me. And so, and those do exist. But everybody's different, and extrapolating somebody else's story often is not going to be the correct thing to do for an individual. So really educating oneself on exactly what their diagnosis is, and that can differ not just by body location, but also specific cell types, and even specific molecular differences among these cell types can determine which chemotherapy or targeted or immunotherapy is right for them. And very often there are combinations of these types of therapies today. So the waters can get very muddy. But I would say in general, when we talk about, the term I mentioned, cytotoxic chemotherapy, those traditional chemotherapies that we think about that kill dividing cells, there's a lot of commonalities to the types of side effects we see: nausea, fatigue, sometimes hair loss, sometimes nerve injury, sometimes affecting the circulating blood cells in our body, like the red cells where you can get anemia, or the white cells. You can lower your immune system to varying degrees, and the platelets. So those are just a few of the common things that we see. But there are some chemotherapies that will cause your hair to fall out, and some that won't, and some that will cause nausea, and some that don't do that so much. So the individual type of chemotherapy really matters. And sometimes there are combinations of several chemotherapies at once, and it can get a little confusing. But it's really important to spend time with the treatment team and educating oneself about what are the possible side effects about the specific treatment that's going to be involved here. When we're talking about targeted therapies, those are often in pills, but sometimes they are intravenous antibodies. And antibodies are these Y-shaped proteins that go in the body and bind to one specific thing, whatever we decided in the lab that it should be binding to. These pills or these antibodies will go after one specific target, part of the mechanism of the cancer. Those treatments can sometimes have very few side effects, but sometimes can have really difficult side effects. And sometimes these pills can be harder on the body than the traditional chemotherapies. There's a tendency to think, oh, it's a pill, it's targeted, it's going to be easy. But that's not always the case. Even when there are side effects that aren't necessarily dangerous, some of them, you can get severe acne, or you can get diarrhea, or you can get just fatigue and a little bit of a tummy ache. And these kind of chronic symptoms can really wear on somebody. So a pill isn't always easier. And these antibodies are all over the place. There are so many different types. The field of targeted antibodies, even though all of them are these Y-shaped proteins, they all sound similar, the target that they target has a big influence on exactly what kind of side effects they're going to be. Antibodies are generally going to be intravenous, but these days sometimes they're subcutaneous as the technology is advancing. And a lot of the new immunotherapies are also antibodies. And when we talk about immune therapies, we're really talking about harnessing the immune system, which is pretty amazing. Our body, in so many cases, is able to fight the cancer with its own inner technologies, its own wisdom. It just needs to be given that permission. However, the risk of these immune therapies is sometimes when we unleash the immune system, it can go after some of our normal, healthy cells. And so some of the immune therapies carry the risk of causing inflammation in our normal organs that can mimic autoimmune phenomena. Yeah.
Well, you brought up a really interesting point when you were talking about the tailored or the targeted therapies, and that how some people think, well, I would just want that because it's just a pill and that's going to be easier than the traditional chemotherapy. And one of the things that's interesting that I see sometimes, because people come to me for not a second opinion about their conventional therapy, but they're wanting kind of another person to look at the broad picture and help them make decisions, right? And then put a holistic plan in place to help them, with symptoms and get to the root cause and that kind of thing, more of a holistic approach. But I will often run into people where they're like, I don't want to have, and I'll just give this example. This was a woman who had breast cancer, and she's like, I don't want chemotherapy with Taxol because Taxol is a drug that is so old, and it's archaic and all of this stuff because it was an old drug. And so she wanted some new targeted agent. And I don't even remember what it was at the moment, but a person who's practiced in conventional medicine for 2 decades before I left the system, I'm thinking, you know what, I kind of want the drug that I know what the side effects, and I know the history, and I know the data, that we have decades of data around this, how it works, than something that what the other agent that she wanted was not even something that was approved. It was a trial. And I was like, first line therapies, and maybe we can talk about that actually, like how is it decided, first line, second line, third line, so people can understand that if you're going to go a conventional route and, cytotoxic chemotherapy is recommended as first line, there's a reason for that. And so can you speak to that? Like, you know what I'm talking about. I'm sure my audience doesn't know fully what I'm talking about yet, but I would love to have this conversation.
Yeah. You raised some very, very relevant and important points here. Chemotherapy, even though some of it is many decades old, remains the cornerstone of treatment, systemic treatment for so many different types of cancers. And here and there, we're seeing instances of where new, less toxic treatments are replacing chemotherapy. But for most of the common cancers, chemotherapy remains a cornerstone of treatment. And it's excellent. And I would say about chemotherapy, it's fairly predictable. Individuals will have different sensitivities to different toxicities. That's 100% true, but we know roughly what's going to happen. And we have a lot of data about the effectiveness of it. And also we have the advantage, these are for the most part very inexpensive drugs. We don't have industry pushing to get Taxol. Taxol is used because it's a great drug. Whereas some of the new drugs that are coming out may have some marginal benefits that in these very large studies show, incremental PFS advantage, whereas most patients may not be really benefiting to the same degree that they're benefiting from chemotherapy. So certainly that history of use is really important.
And can you describe, because I'm in this now alternative space, but I bridge really people who are going to do conventional, as it's written, and then people who are like, oh, I'm not doing any of that, and they want to do a water fast or whatever. And then I have people in the middle. And actually the biggest dangers that I see are sometimes in the middle, because people want to Frankenstein and put together, and they're like, well, I don't want that drug because of this, whatever. They have some experience or they've read something, and then but I want this, and they want to put stuff together. But there's a way that you decide on what is the first treatment for someone versus, okay, if it comes back, then, we've tried this and this hasn't worked, then we're going to do this. Can you describe how are those decisions made? How is it decided what treatment is going to go first? And would you ever recommend people convincing their doctors to combine drugs in different ways that the studies don't necessarily support?
I would say that for different cancers at different stages of the disease process, there are different levels of how compelling the data are to support specific regimens. Very often the first line systemic regimen, the first thing you receive after surgery or before surgery, there's going to be the most data for. And that's what's going to, usually whatever the standard of care is going to be pretty well established. And also importantly, very often the first line treatment may be an opportunity for cure. Whereas if for a recurrent cancer, may or may not be an opportunity to cure. So if you have a potentially curative therapy, that's something that you may not want to forego if there's a reasonable chance that it's going to do that for you. Whereas in the later lines of treatment, when somebody's getting third or fourth line and maybe there's not really an established standard of care, there's a little bit more flexibility. Ultimately, a patient has the absolute sovereignty to make the decision for what's best for them, for their body. But I would absolutely advise to take that recommendation for first line treatment very seriously when the stakes are very high and the data often are very strong for the benefits. And in terms of how to integrate some more holistic therapies, that's something that's ideally done in collaboration with the conventional doctor and the integrative doctor. And unfortunately, there's not a lot of direct communication that goes on for perhaps ideologic reasons and for perhaps practical reasons, that there's a variety of barriers to that. So I would encourage patients to maintain open communication in both directions, and not to have to apologize for anything, and just be very plain. This is what my preferences are, and this is what I'd like to do, and I'd like to do this safely, and I appreciate your support. And hopefully most physicians will be attentive to that and caring to that, because most patients really are looking for something more outside of what we can offer. We very often are offering really difficult therapies, and sometimes with limited promises of what they can do. So it's completely understandable to look outside these walls. And I think the more that we talk openly about this, the better. But also for patients to really be educated and think about this. I mean, so often there are, trends on on the internet, or there are unscrupulous salespeople out there trying to take advantage of patients who are in a desperate situation and making a lot of false claims. And I think, it's very important to use discernment about what is really sensible for you in your journey, and what, maybe not such a good idea. And so it requires really just paying attention, asking a lot of questions, doing research, but doing good research,
Yeah. Well, and I think that I love that you said that about the communication, and that's, there's an episode for my listeners. I've recorded another episode with Dr. Konner with one of his patients, who's also one of my clients, who did a water fast. And he, you, speaking to the listeners about you, but basically you have been such an ally and open physician to the other, things that Donna, my client, and your patient has wanted to do. And so I've always said that we're always do better if we're all working together and we can communicate. But I think one of the things that's difficult for many patients is that their doctors are not as open as you are. You've been very open. You're always clear, like, my primary goal is to keep my patients safe. And so you're always looking out for Donna, like, make sure whatever you're doing that is safe. And then if we're doing anything at the same time that she was having some systemic therapy with you, that nothing would interfere, and making sure. So I 100% agree with that, with the communication. What do you say to someone who's seeing a doctor and they are really interested in doing holistic practices, and they're just like, their doctor is saying, because I heard this just the other day, like, you can't do any of those things if you're going to have treatment here. Yeah. Like, you can't do any supplements. You have to stop all of that. You can't do anything. Yeah. What do you say to that?
Well, I think that the relationship between a patient with cancer and their medical oncologist is a really important one. It's a really sacred relationship. And I think that's at the core of the patient's journey with conventional medicine. So I think it's just stepping back from that question. Am I being listened to? And can I express my needs and issues, in a safe and supportive environment? So I think it's just really important to make sure that you feel, that an individual feels comfortable in that relationship. And so if their team is being completely dismissive and doesn't want to discuss, and there's a lot of ego in the room, and like, oh, I know more than your Google, and things that come out, then I would be wary of that, not just for that question, but just is this doctor's ego coming in the way of my needs in general? Because I think that's a big issue in the field. I think that, when ego enters the relationship, it's bad for the patients and it's bad for the doctors too. And that's something as a field that we need to work on some more. And sometimes it's ego, and sometimes it's really difficult to do anything more than we're doing in a day, because doctors are really stressed and strapped for time, and they just don't have the bandwidth to do more than what they're doing, or don't want to put in that extra time. And that's understandable that a lot of doctors are burned out. And then sometimes there are very good reasons. For instance, if a patient's on a clinical trial, a lot of clinical trials can afford, great things to patients these days. So there's a lot of exciting, beneficial new medicines on trials that are coming out. And very often there are very strict rules that are really there for safety, because if a drug is new, we often don't know what the interactions are going to be and what the pharmacokinetics, or, how it interacts with the body and is expelled from the body. We don't really know the details of that. So in the setting of a trial, it's really important to be super careful with supplements and other treatments. So I think understanding why the doctor is responding this way is the first part of this. Is just someone I can communicate with, and do I feel safe in this relationship and listen to? I think those are the first questions.
No, I think that that's super helpful. And I love that you brought up that other point of why. What is it, just that they're completely closed off and not open to hearing what's important to you? Or is there really a valid reason why in this particular setting it's not they don't want you doing anything extra because it actually is required by the clinical trial to, be explicit about what exactly people are taking.
Yeah.
So I think that that's important. And I think, this is the one thing that I always say to people is they're like, the doctors, it doesn't feel like a good fit. They're not listening to me. I don't. And then but they're afraid. And I always say, it's okay. They are so busy. It's okay if you go get a second opinion or if you switch to a different doctor. This happens all the time. Like in our clinic, we had, people would end up switching oncologists and no one thinks twice about it. Because if you think about it, we're human beings and we're developing a relationship and we're not going to be a match for everyone. And so that's one of the things that I would like to at least allay people's fears, that if you do find that this isn't the right fit for you, it's okay to switch.
Absolutely.
It's okay to look for another doctor or even in the same clinic.
Yeah. Yeah. I think that that relationship is so core to the healing process, and it's not really supported by the system. Writing chemo and looking at labs and sort of the basic, more substantive, recordable things are what are demanded of us and asked of us. But ultimately, what is so important is that relationship and that listening and that conversation. And that sometimes gets lost in the shuffle of the process.
Yeah, for sure. Well, and I don't expect any conventional doctors to be abreast of this other stuff because that's not like you said, that's not their job description. They have all these things that they are responsible for. But I think the big thing is if this is important for you, is just to have someone who's open. And then I would find, a holistic practitioner who can then communicate and help your doctors, say, okay, these are the things that we're doing, is this okay? And like when I was practicing radiation oncology, if someone was going to see a naturopath, I'd be like, just let them know this is what you're having done, send them a list of what they want you to be taking. And then everything's great. Then everyone knows and we're all working together and keeping you safe.
Absolutely. I think that the field is stacked against this type of relationship. I think that conventional medicine doctors come into the field without having this openness in their hearts, because that's not the way that they're trained, and that's not the way the zeitgeist of the field often is. So I think so often these things are missed.
Yeah. Let me ask you this, so with targeted therapies or immunotherapies, are there some things that you would have people, knowing that it's nuanced, knowing that it depends on, what signal abnormalities that they have in their cells and, genetic profiles of their cancer, are there general things that you might advise people to be aware of or before going into these therapies? And I know that's a broad question, but maybe even if you just had examples of, specific targeted therapies or immunotherapies, just so that I think one of the things that I always want to do is help people to know what are the right questions to ask. Like, what are the questions that I should be asking when I'm, offered different therapies? Yeah.
The one thing is that these treatments, as we were saying before, they're just not right for everybody. And it really depends on the cancer and some of the molecular details and on the individual. So you want to think about all these issues. In terms of molecular details, sometimes there are different proteins expressed on the cancer that we do special what are called stains to look for different proteins that will tell us whether or not this drug or that drug might be best for an individual patient. And sometimes we do comprehensive testing of the DNA of an individual's cancer. And that sometimes reveals incredibly valuable information about what exactly is the best treatment for this patient. Sometimes it's not helpful at all. Depends on the cancer. And sometimes those tests can be done with blood tests. And sometimes they're done with the tumor that was taken in the biopsy or from the surgery. But that's a question that should be, on almost everybody's minds. What is my cancer? What is the subtype of my cancer? What are the molecular tests that have been done or need to be done to help make sure that I'm finding the right treatment for me? Because using targeted therapies, if you don't have the right target, sometimes can cause a lot of harm. And similarly with immunotherapies, some of these molecular indicators can have a very strong impact on whether or not the patient might benefit from this treatment. In addition, there are patient factors that need to be looked at. So, for example, as we mentioned before, we're sort of recruiting the immune system into action with a lot of these immune therapies. And if autoimmune phenomena are potential consequences, we have to ask, has the patient a history of any autoimmune disease? And that might that come back? Someone comes in and they look fine, but they just had rheumatoid arthritis that has been sort of quiet for the last year. If they receive an immune therapy, they might be at risk of reactivating that. Asking about those things and just being aware of those things in one's history are really, really critical.
Well, and I love the questions of, okay, what is my type of tumor? What is the subtype? What is the testing that either has been done or needs to be done to make the right decision for therapies with this? Once they've been presented with therapies, what are the things that, people should be asking? Obviously, when I'm talking to people, I'm always saying you want to understand what are the benefits of that therapy, right? And then what are the short-term side effects or risks while you're having the therapy, and those are things that won't last forever, but they can be, significant in terms of quality of life. And then what are the potential long-term complications? Is it for you the same thing? Are those the things that you would tell people that if they were presented with a therapy, those are what they should be asking about?
Those are all really important questions. I think I would add to that, what are the foods or medicines that I need to or don't need to avoid while I'm doing this? Or what are the activities that I need to or don't need to avoid while I'm doing this? Because some patients have the presumption that on treatment they need to live in a bubble, or they can't have sushi or drink alcohol, or they start depriving themselves of seeing a family member, like a baby. They don't hug a baby because they're scared they're going to affect the baby with these toxins that are coming out of them. And if it's really important to ask these questions, because not knowing these answers can really affect somebody's life if they suddenly were like, well, I need to take all these precautions that you don't necessarily need to take. So I think those are really sometimes overlooked questions that are not asked, that I would bring into the conversation. With immunotherapy, there are increasing data coming out about various things that can potentially decrease the effectiveness of immunotherapy. For instance, overuse of antibiotics. And that may not be obvious, but that's something to look into. Even use of probiotics, certain types of probiotics can decrease the effectiveness of immunotherapy. So really fleshing out those sorts of questions I think can be really valuable for patients. What do I do when I'm not here?
Yeah. Well, no, I think that's actually really important that I didn't think about that, like, the foods to avoid or, have while you're having chemotherapy, the activities, because I'm assuming that their doctors are going to tell them all of that. But you're right that people sometimes make assumptions and it's something that their doctor hasn't asked. So asking those questions is really important. And, it's interesting. I hadn't heard that about decreasing the efficacy with antibiotics or probiotics. So this is one question, is that, when people, they go in and they see the oncologist and then they come out with some crazy new drug that's like, I can't even spell it, let alone pronounce it, and it's like all these things. And they're just like, I don't know, it's, they don't know whether it's targeted or immunotherapy. If someone goes, and this is just a question for you in general, so for people when they go to Google, because they are going to look up these drugs, or, also they should have a printout from their doctor. Would it say specifically in there that this is an immunotherapy drug, or no, right? Because that's
Not
like,
so
how do they
much.
even know that it's an immunotherapy drug?
I mean, that's a framework that I often use to discuss with patients, but they're not clear categories at times. And as the technology is advancing, There are some drugs that don't fit neatly into these categories. And there's a huge new field of what are called ADCs, which stands for antibody drug conjugates, where you have these Y-shaped proteins, the antibodies that bind a target, and they carry with them a chemo. So I think of it as targeted chemo. It's both targeted and it's chemo. And then we have some other antibodies, these Y-shaped things. Normally, they bind the same thing on both tips, but now we have some that bind one target with one tip and another target with the other tip. And one of them might be an immunotherapy target, and the other might be a targeted therapy target. So there's a lot of overlap with some of these emerging treatments that are becoming really common. I think that that's a nice just overall framework for patients to think about, to get comfortable with this. But as you dig deeper into this, it can become a little more complex.
I think it is becoming so much more complex for you. I know just in oncology, I think you and I actually started practicing around the same time. My first position out of residency was 2006. I think you were similar
around 2004.
Okay. Yeah. So, both of us have been practicing for 2 decades. I remember when I first started practicing, there were, the chemotherapy regimens. It was very specific, and we had hormonal therapy, but none of this stuff existed. And then I remember it's probably like now, maybe 10 years ago, that it just started exploding, and the amount of information, even for the doctors. This is one of the reasons why, as a medical oncologist who does these systemic therapies, you often end up specializing in a specific type of cancer because it's so complex, even within that, to keep track of all of these therapies and all of these targets and all of this new emerging, pharmaceuticals are becoming available. For the patients, it's almost like mind-boggling. They can't even, because when you can at least put them in categories where you're like, okay, this is a conventional chemotherapy, this is a targeted therapy, this is immunotherapy, they can somewhat wrap their head around it. But now it's so challenging because you're right, like it's so complicated, and then maybe they're mixed. I didn't even know this was a thing, the mixing of the two. Yeah. And so I think, the question, I guess, is that, or I guess the challenge that I'm seeing, because I see people on the other side of it where they get these inserts and they're just like, their eyes are just, like spinning because they just can't keep track of any of this. They're really reliant on their doctors giving them accurate information, more so even than in the past where you had just these, specific regimens. It was like breast cancer was like, we're doing ACT or whatever it was. And it was, a lot of people getting that same thing. Now everyone's getting something different because, as you described, everyone's different. Everyone's got, different features to their own cancer. But then it becomes even scarier, I think, for people with some of these therapies because you don't have as much information, and there's so many different ones of them.
Yeah, this is a huge point. The more we learn and the more this field is differentiated, the harder it is for individuals to keep up with all this, and they become increasingly specialized. And I think people don't realize also that rare cancers are really common. So, and there are 400 different types of cancer at least. And so if you added up all those rare cancers, those are as or more common than the common cancers combined. So it's really common to have a rare cancer. And sometimes it can be very hard to get good information. And it's been impressive how there are some patient-led grassroots movements of just coming together, often on these Facebook groups, to really just share information about these rare cancers, especially with patients who aren't close to an urban center where you might find the right specialist. And so that can be a really valuable resource. Sometimes you might not find great information, but sometimes patients can find really amazing information on some of these groups. But yes, it gets so complex, and even cancers come from our own bodies. So they are at the core as individualized as we are. And they evolve over time. And sometimes even in different parts of our body, we're treating different entities. And so the oncologist, as an oncologist, I form a relationship with my patient's specific disease. This particular cancer, likes to grow quickly and then respond well to chemo, or this particular cancer, the tumor marker is very sensitive. And you start to learn these things about individual cancers, some of which really have no precedent. And I so often get the question from patients, have you seen this before? And the answer is always yes and always no. Because I've never seen exactly this, no matter what it is, and no matter how much I do this, I have never seen exactly this. Everybody's story is different, but I've seen enough that I can get a sense of what I might do here. So it really, can get very, very nuanced. And yes, the more we know and the more we learn, we're keeping patients alive for longer now, and it's really amazing. But things get even more complex as you get to fifth line therapy and sixth line therapy with different diseases, and there's more and more drugs coming out. So the struggle is real, for sure. And being a generalist, I think, is just really, really hard. So it can be valuable for patients to sometimes get a second opinion, even for one critical decision-making time in their disease with a specialist if they're not sure if their doctor is familiar. And very often I'll see patients whose doctors are very welcoming for a second opinion. I think so often patients are scared of offending their doctor by seeking a second opinion. And I think it's really important to know that it can be really refreshing and really great. And the generalist is like, do it, great. I am so excited. I want to know. I want to see if we can share knowledge. So I would encourage patients to really be open to that, because very often doctors are open to that. And if they're not, that comes back to some of the ego and dismissive issues that we were discussing before. But I think in general, that's a really, that could be a really valuable thing for patients.
Yeah. Well, and I always say, look, when I was practicing, I'm like, getting a second opinion is great, because either you're going to go and you're going to see them and they're going to confirm that the plan that we've developed is what they would recommend, and then you're going to feel good about that. Or if they come up with something different, then that's good too, because maybe they're looking at it from a different perspective. And I'm always open to that. And I think actually that is a sign of a doctor that you want, someone who is open to you going for a second opinion, because the truth is that if there's the option for a second opinion, it means the first one is also an opinion, right? It's not like gospel that when a doctor sees you and this is it, this is the only thing, because you could see multiple doctors and maybe get multiple different answers, which I don't think is necessarily a bad thing. It's good actually to have, the more minds you have thinking about something. I think it can get problematic. People can go for too many opinions and then they get very confused.
Yeah.
But I think having a second opinion and being able to either confirm what that first opinion recommended, or to be able to look at from a different perspective, and then you're just getting, good information.
Absolutely.
And I loved what you said about the Facebook groups. And I think that this is really valuable for especially some of these, like I'm thinking about, there's one that I saw for hepatocellular carcinoma, or it was neuroendocrine tumors of the liver. Like they get very specific. But what's beautiful is if you can find one of these where it's well run, and they're bringing in good people who have, real knowledge in this area. And usually it is the rare ones. It's the ones that you don't have. And then they've got a champion kind of doctor who's very knowledgeable in this region who'll come in maybe and talk. Those groups can be very helpful to gathering information.
Absolutely. And
there are some Facebook groups that can be really problematic, where you're just seeing people are just spewing stuff that is like not at all science. They're just like, they're just giving their opinion. And so you had to be discerning. And I think that for anyone listening, those Facebook groups can be great. And you want to be really cautious when you go in, and you want to look at the things, what is allowed to be posted. If people are just posting their own experience of just one person having a specific experience, that's not going to be super helpful, because like you said, I mean, you said this and you've seen thousands of patients. It's like, yes, I've seen this before, and no, I haven't seen this before. So one person who's experienced this type of cancer certainly doesn't have the perspective, the broad perspective or knowledge to really, understand the full depth of complexity here. But I think the groups can be helpful just in terms of gathering information.
Absolutely. And also finding specialists who can give a good second opinion. That's a good place to exchange that sort of information. And And yes, I mean, the art of medicine is still very much alive. Even with all our technology, it's still a critical component of this. And partly because, the gold standard of data that we use, the randomized phase 3 prospective clinical trial, those take a long time and are really expensive and don't happen very often. And in the meantime, we have a lot of new information coming out. And how does this apply to the individual? Or if you have an individual who wouldn't have qualified for this very specifically defined randomized phase 3 clinical trial, how do we extrapolate those data to this patient? So judgment and the art are still very, very relevant for individual patient decisions. So a second opinion can be really valuable to put more heads together on that.
Absolutely. Well, Dr. Konner, it's been a pleasure again to chat with you. I'm wondering if you can tell people where could they find you if they're interested in learning more about you.
I don't have much of a social media presence. I'm on this Sloan Kettering website. I don't know how interesting it is there. And I think I'm discussed in a lot of these Facebook chat groups, so I never really visit them. But I think a lot of information about me can be found there, I'm told.
Yeah. Well, I'm so grateful that you're coming on here to share your wisdom with us and with my audience. So thank you so much for being here. It's always a privilege to talk to you.
My pleasure, Katie. Happy to be here.
Thank you for being here today. Please enjoy a previous episode of Born to Heal. And if you found value in our conversation, please subscribe and share with someone who might benefit. Have questions? Drop them in the YouTube comments or message me on Instagram. Links are in the episode description. And remember, just like me, you were born to heal.